So, excuse me, anything that you, any of the recordings that you see today, including Dr. Nguyen's, will be available online for CME credit. Next slide. So everyone, welcome to Family Medicine Grand Rounds. Today is November 18, 2020. Our event ID is 323047. As a quick reminder, please remember to call in, use your smartphone or your computer so that way you are able to get CME credit. Next slide. Thank you, of course, to everyone for muting your microphone once the presentation begins. If it becomes unmuted, we will actually mute it for you. Of course, being attentive to the presenters and being engaged in the session. And of course, please at the end complete your evaluation. This is, of course, important to the presenter, but also to Grand Rounds. Next slide. And of course, we present Grand Rounds with our educational partner, which is South Central AHEC. So thank you. Next slide. Just quick reminders that CME transcripts can be achieved online. This time we went ahead and kind of outlined what that looks like for you if you do it on their website. Next slide. We also provide, of course, credit through AAFP credit system. So of course, please make sure that we have your correct AAFP ID number. Next slide. And we would, of course, like to point out that Dr. Nguyen has no relevant financial interest with commercial interest to disclose. And so having said that, next slide, I will introduce Dr. Nguyen. He is an assistant professor with the Department of Cardiothoracic Surgery, specializing in robotic general thoracic surgery. Thank you, Dr. Nguyen, for being here today, and please take it away.
Thank you very much. I'm Dr. Nguyen, new faculty on the thoracic surgery service, part of the cardiothoracic surgery department at UT. I started in May, so I've been here about 6 months, so getting settled in this whole environment. So the objectives of this talk is to talk about what thoracic surgery is. You know, our presence in this field has been, we've been here, my partners are Dr. Johnson and Dr. Gierman, but I just wanted to reintroduce all of us. And one of our interests are in foregut disease. One of mine is benign foregut disease. Dr. Scott Johnson tends to do more of the complex foregut and esophageal cancer cases, but I want to talk about you know, disease processes, diagnosis, tests, referrals, and how to talk to your patients about treatment options. Right. So this is just a little background on me. You can pronounce my last name as Nguyen. That's easy. I'm from Maryland. I did medical school in Philadelphia. Did a general surgery residency at George Washington in DC. And then I've been in Boston and in Houston for my more formal thoracic and cardiothoracic training, finishing up earlier this year. So this is just a little nod to my mentors along the way. David Rice from MD Anderson, Dr. Gerd that got me into thoracic surgery, and then Dr. Brian Burton, Dr. Sean Groth over at Baylor in Houston that trained me most recently. And Dr. Sugar Baker, biggest name in thoracic surgery. He created the program at Brigham, and he really drove the ship in determining how to deal with mesothelioma surgically and non-surgically. And unfortunately, he passed away last year. But all of the trainees under him have been trying to continue his, you know, his philosophy of clarity of purpose and focused attention. So we really do our best to try to make him proud. So what is thoracic surgery? So, you know, the simplest thing, it's surgery in the thorax. And formal training in the States includes both cardiac and general thoracic surgery. So we call general thoracic surgery. It's in the general thorax, I guess, but it's really non-cardiac. So anything you can name in the chest outside of the heart and the great vessels is basically what we do. That includes the lungs, mediastinum, chest wall, diaphragm, hiatal hernias, esophagus, and some of the stomach and the thoracic outlet. So again, I'm focusing on benign esophageal diseases. And the two I'm focusing on are gastroesophageal reflux disease. They're associated with hiatal hernias and also achalasia. And the reason I want to bring these up is because they can be tricky to diagnose and difficult for both the primary care, emergency room, and the patients. And oftentimes when they get to me, they've spent years dealing with this disease and not really clear about the pathways of what their options are. So I'm trying to help elucidate that and educate so that at the end of the day they can be more informed and get to me at an earlier state if they feel like that's best for them. So Gerd, I'm sure all of you are well familiar with what that is. It's a chronic condition of abnormal gastric contents flowing back in the esophagus. So there is normal reflux to some degree, but when it becomes abnormal, people have chronic pain and a lot of symptoms. And this next slide goes into the typical and atypical symptoms you have. So typical ones: heartburn, chest pain, regurgitation, bloating, sensitivity to different foods. And you'll find a lot of these, patients will be changing their dietary habits over time. So it can be a little confounding on what their symptoms are, because they may eat less, or they may sit up more or sleep on pillows, all kinds of things to prevent these symptoms from happening. They can get quite used to that lifestyle. And then you also have your atypical symptoms, which tend to be more on the respiratory side. So chronic cough, difficulty swallowing, asthma, hoarseness, all kinds of things that a lot of people take for granted, but it could be undiagnosed atypical symptoms from reflux. So just getting a little bit more into the anatomy of things and how the anti-reflux mechanism works. There's been a lot of work on this, for 50 plus years, but generally what's accepted now, there are four main components. There's the diaphragm, the intra-abdominal esophagus, the lower esophageal sphincter, which technically isn't a formal sphincter, but it's a region of the distal esophagus, and then this gastroesophageal valve formed by the angle of His. So this, I'll just go over that a little bit. So this picture just shows what a normal G junction for the most part looks like. You have the intra-abdominal esophagus, this angle of His. You can see a flat valve is labeled on the right side. The idea of that is when the stomach fills, that flap moves over to the esophagus and basically closes it off as you fill the stomach. The importance of an intra-abdominal esophagus is that your stomach or your abdomen has positive pressure, so that'll help that area close too. And then combined with the muscular diaphragm and the lower esophageal sphincter, those are all important components. Now, if there's a breakdown of any of these components, you can understand that there's an increased likelihood of reflux. And oftentimes, once this starts, there's a whole cascade leading to everything, being in a non-natural position. So this is the right side shows what a classic hiatal hernia, or in this case, it's a sliding hernia, but how it breaks down all those components. You have your esophagus now all in the chest, and that's a negative pressure, space. So that would encourage contents to go from the abdomen to the chest. Lower esophageal sphincter is above here, so it's not really working well. And then you lose that, you get effacement of that valve, so that doesn't really work. So all these components can lead to that. And whether it's a small hernia or a big hernia, they can all have different degrees of reflux. And another aspect of this is a person that has a little reflux may have a lot of symptoms versus someone that has a lot of reflux that doesn't. And that makes this even more confusing for the doctors to sort out. So how you diagnose, everything starts in the office, history, physical, and you go over all the symptoms, what they've done to make it better or worse, diet, do they take medications or Tums or PPIs, and how do they respond to this? Does it make it better? And that's important on trying to give them a prognosis on how well further treatments or surgeries can go. So most start with the PPI. That's semi-diagnostic, because if they improve, then that may indicate they have reflux, though that's not 100% technically too. And I've had some examples of patients that have improved for different reasons. And personally, I think it's probably because they may have some degree of gastritis that's confounding the picture. But usually they end up, at least when they get to me, they're getting worse. So the studies I like are these 4 to 5 studies: the contrast esophagram, a pH Bravo, a high resolution manometry, and an EGD. And then if there's any concern, a formal cross-sectional imaging with the CT scan. So I'll go over each of these. So esophagram is what you usually want to start with, because it's a simple, non-invasive procedure, and you can see, you know, how well the esophagus is contracting, if there's contrast that's pooling up in a column, or if it's refluxing. You can also see a hiatal hernia, such as in this picture. And you can also see other pathologies like diverticula or strictures, things that could make things a little surprising if you do an endoscopy on them. You could cause injury if you have something like that and don't foresee it. So we generally like this as a first study. pH Bravo, that's relatively newer compared to the pH monitoring before, because in the past you have to have a catheter going in the nose to the stomach or above the stomach and measure that, and that's pretty uncomfortable. The Bravo is basically a wireless device that temporarily attaches to the distal esophagus above the GE junction, and it can monitor the pH level there. And it can stay there for 24, 48 hours, and then it will slough off and get passed with a stool. And there's a wireless transmitter or a controller that the patient wears on their belt, and they can push a button every time they have symptoms. So gathering all this data, there's a a report that's provided to the person ordering it, and then there's also a composite score called a Demeester score. Demeester is a surgeon from USC that really would focus a lot on foregut surgery and really set the stage on how do you diagnose and everything. So he has a score named after him, and he's actually still pretty active in that world. And I'll go into the techniques later that he's been advocating most recently. But the key thing in here is if you have a Demeester score over 14.7, you likely have reflux. That's not the 100%, because you have to whittle down to the further details to really understand when the reflux happens or whatnot, but that's a good start. The thing about any pH test is you have to be off of your proton pump inhibitors for at least 7 days. Some people say 2 weeks. And then if you're on an H2 blocker, you should be off at least 3 days. Otherwise, you're not going to see any acid. Now, some patients can't tolerate being off that acid blocker because of their major symptoms. So that may limit you in being able to do the study or not. But that also gives you useful information on how bad the reflux is. High resolution manometry, also relatively new compared to the older manometry, in that this has way more sensors. And I consider it pretty much a standard of care in most places. It's pretty available in most places, and I believe most gastroenterologists are trained in doing it. This is a layout of what you see. It's like a topographic map. The x-axis is the time, y-axis is distance from the mouth. So at the top is where the mouth is, at the bottom is the G-junction. And it's also important that they place this accurately, and that's one area where things can get confusing if you have a really big hiatal hernia and it's like tortuous, but for the most part, they're pretty straightforward. And then the color scheme tells you how intense the contractility is, how much squeeze the esophagus is going. And as time goes by, you can see this peristalsis going down. So this is a normal manometry. And you should sort of see like this mountainous topographic idea going through it in the middle. And when they don't have that, they may have some issues. The reason I get this for a reflux is I want to know how well the esophagus is peristalsing. And if it turns out to be weak or ineffective, then that would affect the kind of repair I do. The three major components are based on this, what's called the Chicago classification. That's at version 3.0. There's actually a revision coming up called 4.0 that they haven't released or told exactly what's on it, but there's going to be some changes on the diagnosis. So stay tuned. But the main things they talk about are these three components. So it sounds really technical, but the main idea of these, if you just see it enough, you get used to it. But the IRP is basically telling you how well does the lower esophageal sphincter relax. And if it's high pressure, it may suggest there's something like achalasia or something. And certainly you want to make sure that the patient doesn't have an achalasia when they have reflux. The DCI is telling you how vigorous the contraction is. So that sort of tells you how strong the esophagus in general. So you want a decent DCI if you're going to do any anti-reflux procedure. And then that just goes into a little bit more detail we don't have to talk about. All patients should have an endoscopy. For one thing, you want to rule out different pathologies, whether it's Barrett's esophagus or cancer or strictures or whatnot. So I like to personally do an endoscopy on the patient after I'm consulted on them. And then the other thing is also to take a look at the gastroesophageal valve. There's a grading system called the Hill valve grade, where when you retroflex, you can actually see that valve because you're insufflating the stomach, so you can sort of see it in action. You should see it as nice, contact between the endoscope and the valve, indicating it's a competent valve. And then once you start getting a hiatal hernia, things start to flatten out, and you see gaps here with respiration in grade 2. Grade 3, it's patchless. Grade 4, it's wide open, and you basically look into the chest because that hernia is so big. And you can see how ineffective this mechanism would be in preventing reflux if you saw that. And then when I see this, I can honestly tell the patient, this is a structural problem. I can fix this, and that should help with your symptoms. All right. So now going back to medical treatment and then surgical treatment, so PPIs, they're really good in stopping acid, and that can help symptoms significantly, but that doesn't technically stop any reflux from happening. So you're going to have non-acid reflux, bile going up there, and there's a lot of opinions on how that is. Is that a good or bad thing? Is that contributing to the increase in adenocarcinoma and distal esophagus? There's no clear evidence for that, but there's a lot of people that believe it. And from the patient side, there's a lot of patients that don't want to be on this medication that long. And I feel like there's a growing concern about the long-term effects of PPIs, which I'm sure you guys are more familiar with than I am. But I hear this a lot when I see patients these days. So I already said that part. So who and when to consult, and that's really just having the knowledge and relationship with your consultants, really. So I really feel with all these difficult diseases, is a multidisciplinary approach really helps. So you can consult anytime. Usually it's the gastroenterologist getting consulted first because they're involved in these studies, and oftentimes they'll consult a surgeon from there. But it can go direct as well. Especially when there's an obvious hernia, and I can tell a patient I can fix that. But if they're having a lot of symptoms and they just really want to know their options, it's we're completely open for whether it's a thoracic surgeon or general surgeon just to talk about it so that they know, and they don't just come when they're in dire straits and saying, just fix me, because even the surgery itself, there's a lot of considerations to do. Okay. So what do I offer, or what do surgeons do? We can repair the hiatal hernia, and we can do an anti-reflux procedure. The goal of this is to really restore normal anatomy, and that's my emphasis, especially how the field's been going the past years. So the steps, I'll go over this a little bit, but I have a video too. But for one thing, you want to reduce the hernia, and part of that is that hernia is sort of stuck in the chest because there's adhesions keeping that hernia sac up, and that's why they can recur a lot, and that's why the esophagus is stuck up there. So you really have to peel all that down and make sure it's completely mobilized to get that intra-abdominal esophagus, and then which is one of the major components of this. And then the diaphragm repair. So the diaphragm hiatus gets stretched out, so you can repair that stitches. And there's some controversy on mesh or not. I'm not going to get into that so much. It's more up to the surgeon, but I personally don't use mesh. And then doing an anti-reflux procedure. And the most common one that people know about is a Nissen fundoplication. And that's the one that's been most studied, the longest history. But also, it's also what I call a supraphysiologic anatomy, where it tends to be a little too tight for some people, and that's where the controversy's been. So this is just a cartoon of how a diaphragm repair is, basically putting stitches in the back. Sometimes you put stitches in the front. And you want to make sure that you have intra-abdominal esophagus not under tension. So you don't want to pull the esophagus down and sort of have a slingshot effect and then repair everything and run away, because that's how things recur. And then on the right, you have different types of anti-reflux procedures. When I was referring to ineffective esophageal motility, you don't want to do a Nissen on those, because then they're not going to be able to swallow. Things are going to get stuck, and you basically didn't do them any help. So oftentimes you do a different, less smaller wrap on them. Okay, so what are the issues with surgery? So recurrence has always been a problem with hiatal hernias, And personally, I think it's an issue with technique. In the past, it was open, and technically going open, it's very hard to get up there and get a good retraction. And even laparoscopically, it's sort of hard to really get things down from the chest if it's a big hernia. And then I referred to the Nissen fundoplication. There's a pretty decent incidence of gas bloat. And gas bloat basically is you can't burp and you're just bloated and you have a lot of flatulence, and it can be very, very uncomfortable for patients. So you know, to the degree sometimes that they do a lot of diet modifications, and sometimes they just want to reverse. The other issues, if there's a recurrence, is that Nissen can slip up into the chest. You can get ischemia and all kinds of problems then too. So those are the two main components. And I mentioned the issues of ineffective mobilization, and that's the main thing there. Okay, we talked about that too. So how do you improve on this? And you know, I feel like the latest approaches to doing foregut surgery is really will show a lot of improvement in recurrence in the next decade. But it's still a little early for that. But the technique is much clearer now between visualization and dissection, and then we can do better within the Nissen. So what I do, I'm a robotic surgeon, so I've been trained in using the Duy C robot, and I do a robotic hiatal hernia repair and what I call a valvuloplasty, which is trained by Dr. Gerd. It's somewhat like a modification of what you call a Belsey, which is classically done through the chest, and an anterior wrap. And again, the goal is to restore normal physiology. So Da Vinci's been around since 2000. It's not new. This is what the newest one looks like. And this is the setup in the operating room. So scrub nurse and assistant at the bedside with the robot. There's a circulating nurse that's helping out with instruments. And then the surgeon's actually at a console on the side. If there's two consoles, you can have your resident on the side too. So everything's done, you know, across the room technically. So what is the benefit of the surgery really? And it really comes down to you just have way more degree of range of motion in there. Laparoscopic tools, you don't really have any wristed action. So, you know, the hiatus is actually pretty far from where you access the abdomen. So you're pretty working far away in a tunnel, and it can be very not ergonomic for the surgeon, and another degree, it can be hard to see up there well. So this robot can really improve visualization. It's three-dimensional view. It eliminates tremors. So for the surgeon that's getting older, you know, that's not an issue. You can scale your movement, so you can be very precise. And, you know, I personally think it's a great way to train residents too, because you're basically right next to them while they're doing things you can take over right away. As opposed to laparoscopic, you know, you got to change positions and do all this stuff. And there's still a lot of improvement in this technology, and the acceptance has grown up significantly in the past 5 years. For this disease process, you can really dissect into the mediastinum significantly, pretty much all the way up to the carina. And the reason I feel that I can do this pretty comfortably is because I'm trained in cardiothoracic surgery, so I'm comfortable in the chest. And some people, some general surgeons are a little antsy about going all the way up because you know, they don't learn the anatomy as well. So that's another reason I feel that I can provide a better repair for a patient. And then you can really suture well. All right, so this is a cartoon of a valvuloplasty. Basically, you're bringing up the stomach and folding up onto the esophagus with stitches and securing it to the diaphragm as well. All right, and that creates this gastroesophageal valve. This is an example of a very big hiatal hernia that I took care of earlier in the year. This patient was very symptomatic, had dysphagia, abdominal pain. Concerning enough that I thought she may have had ischemia, but I did an endoscopy and didn't show that. So, but she was amenable to repair, so we went ahead and did. Anyways, the key thing is, you know, really doing a good medial mobilization, getting the esophagus there, doing a good repair, and then doing anti-reflux. Okay, so our results have been pretty good, and it doesn't matter what the size of the hernia is. This is let me see, is this the right one? This is a picture after the surgery. So you can see the stomach is definitely in the abdomen and the esophagus is going down well. I should have shown a pre-op one. Now, there are newer anti-reflux methods going around, and one is called the Lynx device, and you may have heard of it to some degree, but basically it's a magnetic bead ring that's placed around the distal esophagus, and it has a minimum diameter where it won't constrict anymore, and then it's calibrated so it only opens at a certain pressure. And this is different from what they had several decades ago called the angel shake, because that one was not really calibrating well and it was always holding pressure, and a lot of people had dysphagia and they had to take a lot of them out. So this is relatively newer. I've put several of these in during my training, and I'm working on getting it available at our hospitals here at Methodist and at university. And this is actually a product that Duy C is actually really advocating these days, and he spent a lot of time figuring this out. Okay, so let's see. Well, this may be and you don't have to do a wrap. You just basically measure it out and around it.
We're the same issue again, I believe. I can't hear you.
Okay. All right. Well, I guess I'll just stop the video. So around the distal esophagus. And there's pretty good data. They almost have 10-year data out. The rate of erosions, which is the biggest concern, is about 0.1%, so it's very low. And those tend to be early in their experience when they had the smallest ring, and they've eliminated that. And patients have been pretty happy with it. Usually the patients come in with some interest in it already. So it's going to be only growing in experience. So I mention it now. I'm not saying it's the most dominant thing, but you'll probably be hearing a lot more of it over the next 5 years. Let me see if I can jump back in the slideshow. Okay. So other techniques that exist, some gastroenterologists are doing these transoral incisionless fundoplications. So basically they're going through an endoscope with a special stapler and trying to create that valve again. I think that doesn't fix your hiatal hernia if you have one, so it's very specific. And I've seen a lot of people that come back with this problem and end up needing a surgery, so I don't really recommend it. The same with a stretta, which is a radio frequency ablation of the GE junction. I've seen some of those failures, so I leave it up to a discussion with the GI and me. I'd like to be in that conversation so that the patients really know the full spectrum of their options. All right, so next disease is achalasia. So achalasia is basically failure of relaxation of the LES. So when you have that, it's trouble swallowing, and if it's chronic, then you can have dilation of the esophagus upstream to the degree where it becomes end stage, and you can only fix them by an esophagectomy. And the importance of education here is to try to avoid that end stage achalasia by educating the patient and have them see both a gastroenterologist and a surgeon so that they know their options. Okay, so just going back to basics, no one really knows the mechanism for achalasia. We know that there's a loss of the myenteric plexus in the esophagus on biopsies. Chagas disease does create a similar disorder, but that's pretty uncommon in our country, but you'll see it in South America. And there's some question that it's an autoimmune disease, but that doesn't, that's more on a theoretical basic science idea that doesn't apply clinically. And at the end of the day, there's really no cure. There's really just palliation of symptoms. So, that's something to emphasize for these patients, throughout the process. So again, how do you diagnose? History and physical, and they'll come in with progressive dysphagia to initially solid foods and then to even liquids, and they'll change their diet and all this kind of things. And they may even lose weight. And, they usually appear as younger patients. So if you see an old patient with this, you probably should be ruling out cancer, esophageal cancer first. But older people can also get achalasia as well. So, the same diagnostic studies apply: esophagram, that'll help you out in seeing, you know, the anatomy. A manometry is really important, and then an EGD. So on an esophagram, you can see this bird's beak going on with the contrast as it tapers down to the lower esophageal sphincter, and you'll see a column of fluid there. This left picture shows a pretty big dilated esophagus, and hopefully they don't get to that point when they see you. And then pseudoachalasia can be from a tumor or some kind of external compression. But again, you want to know this before you do any endoscopy because you could cause a perforation if you didn't see it coming. Manometry is really important. The Chicago classification has split achalasia into 3 types. The most classic ones are basically type 1. And part of this whole disease process is you see at the bottom, you know, there's sort of a band of high pressure. And that's present in all achalasia. But then type 1, you don't have peristalsis. So you don't see that, you know, that mountain range, you know, going down on that first picture because there's no peristalsis going on. And you can imagine how difficult that is to eat with that situation. The second one is called Panasonic Depressurization, where, you know, there's just pressure on both ends, and you know, that just builds up the pressure in the middle as things are put in there. And the third one is called esophageal spasm, where there's more of a diffuse spasm going on. And the importance of that is that there may be different ways to treat these that are better than others, and I'll get into that in a second. I mentioned the IRP before that talks about how well your LES relaxes, and basically if it's over 15, then you may have achalasia. There's a sort of a specific classification, you know, numbers by Chicago classification 3, and this may be revised in the next one actually, because a lot of people end up in this esophagogastric junction outflow obstruction because they don't quite qualify as others. And the important thing to note in this whole these high resolution manometries is it's a manometric finding. Okay, so it doesn't mean that's their clinical diagnosis. Okay, that requires a history, physical, you know, all that stuff to put it all together. So there are many people with EGJ outflow obstruction that actually have achalasia. And the key thing for that is you got to rule out other causes for that obstruction, such as a hiatal hernia or some kind of mass on the side or something like that. So that's where getting a CT scan or doing an endoscopy myself can help with elucidating that. And actually, we just had a patient that had a manometric reading of this, but actually had achalasia, and I did a Heller myotomy on him, and he did really well. So this is just confirming that. Right. So in terms of endoscopy, you know, that's important to rule out cancer for one, and then also tells you, you know, how much of obstruction going on there. Achalasia, you can still pass a scope through it. So you usually get this little pop to get through, but you can also do some therapeutics through that. Okay. So, you know, who do you consult? You know, after you do an esophagram, generally you call the gastroenterologist, do an endoscopy and do all these studies like the other one. And surgeon, you know, again, we're open to this discussion from the beginning because the more interventions they get that's non-surgical, that can make the surgery a little trickier. And if the patients get lost to follow-up, you know, they may pop back in 5 years and the esophagus is all dilated out. And, you know, that's when, you know, myotomy may not be as helpful, we can still offer, but they're going down that pathway of maybe they're going to need an esophagectomy, which, you know, in my opinion, it should be completely avoidable if they're educated. In terms of treatments, you have medical therapies, calcium channels and blockers. The calcium channel blockers aren't really that well tolerated. They have a lot of side effects and they don't really last as long. So most people give a shot at Botox, and then dilation is one of the, you know, really well established techniques. And then myotomy is where the surgeon comes in, and then there's another method that the gastroenterologist. I'll get into that. So Botox. It's usually pretty effective the first time, but after that, it starts getting diminishing results and they need it more often. And the thing is, when you inject in there, you're going to cause some fibrosis. You can cause some of the muscle layers to sort of fuse together to make it a little tricky if we were going to do a myotomy. That's all I have to say about that. And then I always found it funny from a historical note, they always talked about the first dilation was done with a sponge tip whalebone. So that must have been an interesting, you know, clinic visit. These days, we usually do a dilation with a balloon dilation. And this is just a demonstration of that. And one of the key things to remember is, anytime you dilate or do anything, there's a risk for perforation. So you got to be careful and make sure you have a backup around, for a surgeon available in case this happens. But it's not, I wouldn't say it's that common. Just be mindful when they're doing it. Again, dilation can cause fibrosis, risk for perforation, and a lot of times they recur, and once they start recurring, more dilations are really probably not going to help them long term, and they should probably get consulted to sent for a consultation for a surgeon. So hilar myotomy is basically you're dividing the muscle. So again, this is a palliative procedure. So you're separating the muscle so only the mucosa is there for the esophagus so that it can't contract there. And then basically turning the esophagus into a conduit and using gravity to let food through into the stomach. The newer one is called a POEM, and I'll get into that. That's either a gastroenterologist, general surgeon, or a thoracic surgeon can do it. All right, so this is a picture of diagram of how myotomy is done, and it's really important to get a significant amount of esophagus proximally divided and onto the stomach to get a complete myotomy. So the guidelines these days say 6 to 8 centimeters onto the esophagus above the G junction and 2 to 3 centimeters onto the stomach, including the sling fibers. And you want to spare the submucosa and mucosal layers. And you can imagine, you could definitely perforate as you're going through this, and you have to take it very carefully. So there's a lot of different approaches. Classically, it was done through a thoracotomy. These days, it's most commonly done through a laparoscopically. And you can, we talked about reflux mechanism and everything. You can imagine doing all this can cause reflux. It's well documented. It's actually about a 40% reflux issue if you don't do a reflux procedure. So these days, most of the time you do either anterior or posterior fundoplication after the myotomy. Again, where does a robot fit in this? And the visualization is really great, but you also get really precise instrumentation, and you can get wristed action. That range of motion really helps out. And I have a video for this, but it's probably not going to show. It's sort of the guy I did earlier. And I'm going to show some pausing it. I'll pause at a certain point. So these are the circular muscle layers that you see there, and this is the hook cautery that can really dissect and carefully divide everything. And then, I'm also identifying the vagus nerve to preserve that, and you can see. And here, I'm starting to work down onto the stomach. In this shot, you can really see the submucosa and the mucosa a little to the left, and then the vagus nerve going up. So this is a wide view of how much of that myotomy is. I'll try to do this more like a. Here I'm starting what you call a door fundoplication, an anterior fundoplication. And that covers the mucosa so that you can feel happy about not perforating anything. And then I also I do endoscopy to look, make sure I have a good grade 1 valve. And, I already saw the myotomy from before. The POEM is relatively new. It's a per-oral endoscopic myotomy. This was first done in Japan, and basically an advanced endoscopist would do this. And I'll show you a picture that'll help more. Basically, they do a little injection of the mucosa so they can elevate it off. They open it with the cautery, and then they're able to get into this tunnel down, all the way down here, and make this tunnel. And then they can divide the muscles, moving from in to out. And once they divide all the muscle down to the stomach, then they can back out and then put some clips or suture it to close that tunnel. And this technique has been around for was it, over a decade now, and it's a lot of experience in America now. But going back, you don't do any anti-reflux procedure on this. So all the studies report about 40% of reflux on studies, in terms of getting a pH Bravo. But most patients say they tolerate it well. And there's only maybe 1%, maybe 2% of patients need a laparoscopic fundoplication of some sort. But in my opinion, it's probably still a little early in making that call. So we're in that wave of, there's a lot of excitement about POEM, and a lot of people are picking up, but I'm seeing it's probably going to swing back to the Heller myotomy, and there's going to be a balance between that with patient understanding. Okay, so that goes into that. And then, of course, there's a risk for perforation. So generally, we have one of the advanced endoscopists is doing POEMs at UT, and we've been called a couple of times for concern for perforation. We work together to make sure we're taking care of the patient and everything, but we're still sorting out, the balance between POEMs and Hellers. So just to summarize, I do all kinds of robotic procedures, not just Foregut. I do lung procedures, and we'll be moving toward, in the next year, probably toward doing esophagectomies minimally invasively. And that was just an overview of some of the things we do, and hopefully that's giving you some understanding of foregut disease and how to talk to your patients about them. On a side note, in terms of referrals to us, we have a pretty good comprehensive multidisciplinary team. We have great nurse practitioners, and I'd say if you get a referral to us, we'll see the patient within 3 weeks, and that's probably better than most of the general surgery clinics we have around, because they tend to be busy with so many different things. So yeah, that's all I got to say about that.
Does anybody have any questions for Dr. Nguyen? You can feel free to either unmute yourself, or if you'd like to use the chat box, you're more than welcome to do that as well. Well, I don't see any questions in the chat box, and so
So I see one saying, how long is robotic training? So robotic training, that's it's still new in terms of getting a curriculum in. So I know general surgery has a curriculum, and a lot of thoracic surgery program have one as part of their training. For me, what I did, I had a lot of interaction with the rep, and I went to training courses. And then in my last year of fellowship training, I went on a course with the AATS, which is the American Association of Thoracic Surgery. They had a 2-day course where you go out with your mentor, and basically you work on a cadaver and a pig, and you spend the whole day talking about how to teach and learn and do it. And that was actually probably the most helpful in this whole thing. But there is a big push to have a curriculum as part of residency. So I'm probably among the first of the generation of people that came out of fellowship, ready to operate. Everybody else basically figured it out. They finished and started their practice. How hard is it to educate patients for Gerd? Any new approach to discuss with the patient in order to avoid surgery? Let me try to interpret that. So, I'd say educating them about, what reflux is and the anatomy of it, to understand it more of a structural issue, structural and functional issue. And, sort of lay out, how the different treatments work over time. So with a PPI, you're taking it forever. If you like taking it, that's fine. But understand that you're still having some reflux. And one of the important things is if they have atypical symptoms, a lot of times they don't respond to medications, and maybe surgery is an option for them. Of course, a lot of them want to avoid surgery, and that's how a lot of them get into these endoscopic techniques. But I'll tell you, you know, at least having a conversation with a surgeon, not that we're going to push you into surgery, but just educate you on the whole grand scheme of things, because, you know, I have a good handful of patients that went through PPI, then they got a stretta, then they got a TIF, and then they get to me, and, you know, they've had all this work already done, and now the playing field is much more difficult because, you know, they had a lot of work done in that G-junction. So I can't guarantee they're going to have a perfect surgery, you know? So that sort of sets them up for a little failure, that they didn't have a conversation with me until after they've had everything else. So I think the best thing in terms of avoiding surgery is actually to talk to a surgeon to know what you're getting into or not, you know? So part of that is, you know, I'd like to develop a relationship with all the referrals so that they know, you know, what you have access to. All right. And sorry there was technical difficulties with the video. I think one of the great things about the robot is that you document everything and can really show everything well so that your referrers can understand what's going on. You know. All right, I think that's it. Thank you everybody for having me. It was a pleasure.
Thank you so much, Dr. Nguyen. We really appreciate it. And if everyone could please, I put the link for the session, but help us give Dr. Nguyen feedback, and hopefully we can get that information to you soon. But thank you so much again for presenting for us. We really appreciate it.
Hopefully that made sense. And then maybe we can sort out how to get videos to show easily. There's different ways to do it.
Okay, yeah, if anybody would like the videos, I'll work with you, Dr. Nguyen, to maybe figure out a way to do that.
Okay, and then I had more to talk about that I took out, so maybe we can set up another session later in the year to talk about more thoracic.
Definitely. Okay, thank you so much.
All right, you're welcome. Have a good day.